Bismillah ar-Rahman ar-Rahim. Welcome to NephroTube teaching case of the month. Today I will present multiple small or short cases. All of them are related to glomerulonephritis. All the lectures of NephroTube, whatever they are, the NephroTube teaching cases of the month or other lectures, are found on YouTube channel. To reach the lectures of previous webinars, please search for NephroTube on YouTube. You will find my channel. You can subscribe for it. Once you visit that channel, you can find all the videos are arranged in playlists. You will find, for example, here a playlist for teaching case of the month. I will upload the record of this lecture in this playlist, and you can find teaching cases of previous months. Here is the hemodialysis playlist in English language, hemodialysis playlist in Arabic language, and so on. So visit the playlist tab to find the lectures organized in playlists. You can also visit the website nephrotube.com, where you can find all social media accounts of NephroTube. You can join us on all NephroTube social media accounts. You can find data about NephroTube online courses, NephroTube books, free video lectures, and you can also download PDF lectures. Let's start by first case. This is a 45-year-old male presents with sudden onset nephrotic syndrome characterized by severe edema, proteinuria of 9 grams per day, hypoalbuminemia, serum albumin was 1.8 gram per deciliter, and hyperlipidemia. So see, this is a full-blown nephrotic syndrome. He has no hematuria, he has normal kidney function, and no known secondary causes of nephrotic syndrome. A kidney biopsy was done, and it confirms minimally changed disease without evidence of chronic structural changes. The question now is, which of the following is the best first-line immunosuppressive regimen for this patient? Is it corticosteroids, or rituximab monotherapy, or calcineurin inhibitors, and the mycophenolate mofetil, or cyclophosphamide and corticosteroid? What do you think? Please answer in the chat box. This is a minimal change disease in adult patient. What would be the first line? Steroids, calcineurin inhibitors, and MMF, or cyclophosphamide and corticosteroids? Yes, as all of you mentioned, the first line here will be corticosteroids. To revise rapidly, the management of primary minimal change disease in adults for induction of remission, if there is no contraindication to steroids, so corticosteroid will be the first line. If there is contraindication or intolerance to steroids due to side effects, you can try cyclophosphamide, calcineurin inhibitor, MMF plus reduced dose glucocorticoids. Rituximab actually has no rule in induction of remission till now. So for induction of remission, the first line is always corticosteroid, and you can try other lines if there is contraindication or intolerance to steroids. Back to the same patient. The patient started corticosteroids, and after 2 months of therapy with corticosteroids, the patient experiences severe myopathy and psychiatric disturbance. This is a very straightforward question. What is the most likely cause of these muscular and psychiatric disturbances? For sure, this is due to corticosteroid. These are two well-known side effects of corticosteroids. This patient developed corticosteroid-induced myopathy and mood changes. Okay, the patient achieves remission, although of the side effects of corticosteroids. The patient achieves the remission or achieved remission on corticosteroids, but relapsed 3 months after tapering steroids. What do you think is the best next step? Reintroduce corticosteroid with a slower taper for this relapsed minimal change. Start rituximab therapy initiate cyclophosphamide. No further treatment observed for spontaneous remission. Please answer in the chat box. Okay, all of you or some of you selected B and some selected C. So this is relapsed steroids. Regarding relapsed steroid, here the choice is always between rituximab and cyclophosphamide. Let's see what KDIGO guidelines said. It will never be reintroduced corticosteroids. Option A in this patient cannot be used because the patient developed side effects from corticosteroids, and also the patient relapsed on steroid. So here, if the patient has relapse, repeat course of the initial therapy, which is corticosteroid, but the patient already had side effects from corticosteroids, and we cannot start corticosteroid. So we have to use another option rather than corticosteroid to induce remission in this patient. The first option will be cyclophosphamide. Rituximab will have role in frequent relapse or steroid-dependent patient. And actually, this is the first relapse for the patient, and we cannot diagnose him. Sorry, this is a steroid-dependent patient. Sorry, this is infrequent relapse. We cannot diagnose the patient as frequent relapse till now because it is only one relapse. So we can use cyclophosphamide even if it is a frequent relapse or steroid-dependent patient. Always cyclophosphamide is the first choice in minimal change before rituximab and calcineurin inhibitor. If there is no previous cyclophosphamide exposure and no patient preference, you can use always cyclophosphamide after corticosteroids. So in minimal change disease, always the first option is corticosteroid. The second option is mainly cyclophosphamide. Going to the second short case, which is also about glomerulonephritis. This is a 12-year-old boy has experienced multiple relapses of steroid-sensitive nephrotic syndrome since age 6 years. At age 10 years, he underwent a kidney biopsy during a relapse that revealed the minimal change disease. So this is a minimal change disease, which is steroid-sensitive, but with multiple relapses. Despite attempts to reduce the frequency of relapses with a short course of oral cyclophosphamide and subsequently a 6-month course of levamisole, he continues to relapse 4 to 5 times per year. Each relapse is initially responsive to corticosteroids, but the proteinuria worsens when the steroid dose is tapered to 0.4 mg per kilogram per day. His therapy has been complicated by mood swings, abdominal stria, growth retardation, and osteoporosis. He recently had a florid relapse manifest with 5 grams per day of protein excretion. His serum albumin is 1.2, serum creatinine is 1.2. What is the diagnosis of the patient response to steroids? Is it partial remission, infrequent relapse, frequent relapse, steroid dependent, or steroid resistant? What do you think? Please answer in the chat box. The patient responds to steroid, but there is a relapse during steroid withdrawal. So yes, as some of you answer, this is steroid dependent. What is steroid dependent? In steroid dependent, I don't know if this image is clear, but to say that the patient has steroid dependence, if there is a relapse within 2 weeks after complete remission, this will be considered as a steroid-dependent minimal change disease. Or if there is a relapse during glucocorticoid therapy when we are trying to taper the glucocorticoids. So steroid-dependent can occur in two situations. The patient had complete remission, and during withdrawal of steroids after complete remission, as in this patient, okay, the patient relapse within 2 weeks, this steroid dependent, or if there is before reaching complete remission, if there is relapse on steroid therapy itself, so the patient is considered as steroid dependent. Okay, so this is steroid dependent patient. Which one of the following is the next most appropriate step in this patient management? Repeat kidney biopsy who has a steroid dependent minimal change disease. Repeat kidney biopsy, tacrolimus plus steroids. Retreat with oral cyclophosphamide and steroids or rituximab. What do you think? I can see in the answers B and D. Okay. The most appropriate answer is D. I know that both rituximab and the calcineurin inhibitors are options in this patient. For sure, it's better not to give this patient cyclophosphamide, because this is a 12-year-old boy and already he had a previous exposure of oral cyclophosphamide. So if there is previous cyclophosphamide exposure, especially in this young age, it's better to avoid cyclophosphamide. So option C is not an option for treatment. So rituximab and the calcineurin inhibitor, B and D. Why rituximab is first before calcineurin inhibitor? Why the first selection should be for rituximab? Because there is a little evidence that both cyclophosphamide and rituximab showed more durable remission in comparison to calcineurin inhibitor. Almost always, the use of calcineurin inhibitor in management of glomerulonephritis in general, whatever it is, minimal change, or for example, membranous nephropathy, the risk of relapse is high after a stoppage of treatment. That's why in this condition, rituximab is preferred than tacrolimus, because the remission with rituximab is more durable than calcineurin inhibitor in patients with minimal change disease, and even also in patients with, for example, membranous nephropathy. This is the dose of rituximab. I will not go through it. So the patient started rituximab. Yes, a very good comment from Dr. AA in the chat box. Also, the patient has raised serum creatinine. So there may be a possibility of fibrosis and sclerosis, and in this situation, it's better to avoid calcineurin inhibitor to avoid the aggravation or amplification of this fibrosis and sclerosis. Fibrosis especially. The patient started rituximab. 1 week later, he reported a sudden onset of left-sided flank pain that is dull and persistent, with no clear aggravating or relieving factors. So this is a sudden onset left side flank pain. He also noticed dark red-colored urine. Remember, this is a 12-year-old patient with minimal change in disease. Now he noticed dark red-colored urine. He denies fever, recent trauma, or previous similar episodes, no recent infection or travel, no history of deep vein thrombosis or pulmonary embolism, no neurological symptoms. Urine analysis showed hematuria with dysmorphic RBCs 5%, negative leukocyte esterase, so no infection. Ultrasound abdomen and pelvis showed normal sized kidneys with preserved echogenicity. So what is the cause of his flank pain? As you all mentioned in the chat box, it is renal vein thrombosis, which it is a common complication of nephrotic syndrome. Nephrotic syndrome patients are at risk of hypercoagulability with increased risk of renal vein thrombosis, deep vein thrombosis, and pulmonary embolism due to decreased level of natural anticoagulants that are lost in urine as antithrombin 3, plasminogen protein C and S. And the presence of dysmorphic RBCs 5% excludes that this hematuria to be of glomerular origin. I will ask you a question. What is the percentage of dysmorphic RBCs in urine that raises the suspicion that the hematuria is of glomerular origin? At which percentage we can say that yes, it is not usual to see hematuria with minimal change disease. But away of this, at which percentage of dysmorphic RBCs that suggests hematuria is of glomerular origin? Yes, as Dr. Gada mentioned, more than 40%. A hematuria with dysmorphic RBCs less than 40% probably is not due to glomerular disease. The third case, this is patient who is 36-year-old woman with progressive edema, 3 weeks evolution. The edema developed on 3 weeks. There is no relevant personal or family history. Studies of autoimmunity and infectious disease negative. She has been using skin lightening creams for several months. Serum creatinine is normal, blood urea nitrogen is normal, serum albumin is low, total cholesterol is high, triglycerides is high, proteinuria about 4.1 gram per day. In urine analysis, there are 3 to 4 erythrocytes per high power field, leukocytes 1 to 2 per high power field, no cylindricals or casts. The case underwent kidney biopsy. Immunofluorescence for all markers was negative, and I will let you see now the light microscopy of this patient. Before showing you the light microscopy of this patient, to summarize the case, it is a case of nephrotic syndrome. After a history, there is a question if there is a renal vein thrombosis. Oh, this is related to the previous case. Is causing hematuria B due to glomerular origin? No, it is a vascular origin. It is the renal vein itself. Hematuria due to the thrombosis of the renal vein itself. It will not be of glomerular origin. Okay. Here she has been. So this is a nephrotic syndrome for with a history of skin lightening creams for several months. This is the light microscopy of the patient. What are the shown findings? Is it thickened capillary wall, cellular crescent, mesangial proliferation, endocapillary proliferation, or normal glomerulus? What do you think? You can answer in the chat box. Is it A, B, C, D, or E? Some said E, B, C, and D. These are the answers in the chat box. A. Is there any other opinion? A. Okay. Actually, it is normal glomerulus. Let's check every point of them. First, is there endocapillary proliferation? No. You can see the capillary lumen in all slides are open, right? The lumen, you can see the capillary lumen in all slides. It is not closed, so there is no endocapillary proliferation. Is there any mesangial proliferation? The answer is no. Take any mesangial area like this, you can see 2 mesangial cells. Here 3 mesangial cells. Here here 3 mesangial cells. Also you can find the same in those. So no mesangial proliferation. For sure no cellular crescent. The Bowman's capsule is totally clear, no cell proliferation. Is there thickened capillary wall? To confirm if the capillary wall is thickened or not, you have to compare the wall of the capillaries to the wall of the proximal convoluted tubule. Compare them. Is this wall of the capillary wall, this capillary wall, for example, is it thickened than the proximal tubular wall? The answer actually is no. The answer actually is no. I don't know if I can zoom it. No, I cannot zoom it. So for more confirmation, this is the electron microscopy of the case. What are the shown findings in these two images of electron microscopy? More than one answer may be correct. Actually, there are two answers in these 5 options are correct. What do you think the correct answers in these choices? A and C, A and D. Okay, right. The correct answer is A and D. You can see food processes effacement for here. There is no clear podocyte food processes. There is a total effacement of the food podocyte process, and this shape is called microvillus transformation. This one, these dots are called a podocyte microvillus transformation, and both of these are characteristic or of the characteristic pathological findings in minimal change disease. So we are facing a minimal change disease in adult women secondary to the use of skin lightening creams. It is well known that skin lightening creams may cause minimal change disease. The fourth case is about a 34-year-old man, farmer without previous diseases, presented with 3 weeks of progressive edema, oliguria, and acute renal failure without macroscopic hematuria. There is a question from Dr. Abdurrahman: is there subepithelial deposition? I will go back to the slide again. In this slide, there is no subepithelial deposits. You can see the glomerular membrane is totally clear. I cannot see any deposits. I hope that I cannot remember if in this lecture or the coming month lecture, inshallah, I will present some cases of minimal of membranous nephropathy with electron microscopy of subepithelial deposits. But here, no deposits at all. This is the lamina rara externa, the lamina rara interna, and the lamina densa. You cannot see any deposits in the pathology. Back to case 4. So this is a 38 years old man, farmer without previous diseases, presented with 3 weeks of progressive edema, oliguria, and acute renal failure without macroscopic hematuria. On physical examination, he appeared well but uncomfortable owing to the generalized edema. So we have acute kidney injury with generalized edema. Blood pressure is high, pulse is good, temperature is good, the patient conscious level is good, and there is evidence of uremic breath due to acute renal failure. Hemoglobin is slightly low, white blood cell count is normal, platelet is normal, hemoglobin is 11.2 milligram per deciliter. 10 days previously it was 1.8, and the blood urea nitrogen now is 135 milligram per deciliter. There is nothing specific in the urine analysis except for 17 gram of protein per 24 hour per day, erythrocytes 300 RBCs per high power field. So we have progressive edema, nephrotic syndrome with hematuria and acute kidney injury in a farmer adult man. Cholesterol is very high, LDL is very high, triglyceride is very high, calcium is low. Actually, for sure, we have to get the corrected calcium of the patient for his serum albumin. Sodium is 135, maybe dilutional because of the severe edema. Potassium is slightly high. Renal ultrasound is normal. Serum complement levels normal. Immunological and virology is negative. Pence-Jones protein is positive with normal electrophoresis in serum, so this is non-specific, and a renal biopsy was undertaken. I will show you now the renal biopsy. It is a spot diagnosis. It is a nephrotic syndrome patient with acute kidney injury and high-grade proteinuria. This is the pathology of the case. Light microscopy, immunofluorescence for IgA, IgG, C3, C1, and kappa, and lambda were negative, but this biopsy was slightly positive for IgM in that was distributed focally and segmentally in glomeruli. What is your spot diagnosis in this case? Please answer in the chat box. What do you see in this case? What is the diagnosis of this light microscopy? Okay, this is a collapsing, yes, as you said, collapsing focal segmental glomerular sclerosis. Dr. Ghada, yes, you said a crescent, but which type of crescent? Is this a true crescent or a pseudo crescent? This is a pseudo crescent. The proliferation of these cells is not a true crescent. This is a pseudo crescent. This is a proliferation, right? This is a proliferation of podocytes, not the true crescent. True crescent is proliferation of the parietal epithelial cells of the Bowman's capsule. So this is called a pseudo crescent, and you can see the total glomerular, the glomerular tuft is totally collapsed with a proliferation of the podocytes. And the classical presentation, of acute kidney injury with severe nephrotic syndrome is one of the characteristics of collapsing FSGS. And the question, what should you exclude? Also, for sure, we have to exclude all the secondary cause of glomerulonephritis. And you can refer to the case that I presented 2 months ago here on NephroTube meetings. You can find it under NephroTube teaching cases playlist on YouTube. I presented a case that was focal segmental glomerular sclerosis secondary to very low birth weight. Please refer to this case. It is a very nice case. Okay, regarding the management for this patient, would you treat this patient with immunosuppressive therapy or just general supportive treatment? This patient, the farmer with nephrotic syndrome, severe proteinuria, and acute kidney injury. Yes, it could be also, we can call it nephrotic also, but the full-blown picture is nephrotic syndrome. Yes, we can consider it, but whatever it is, nephrotic or nephrotic, the presentation is for focal segmental glomerular sclerosis. And now we will treat it focal segmental glomerular sclerosis, whatever the clinical presentation is nephrotic and nephritic. The high blood pressure here may be secondary to the acute kidney injury itself. So we cannot conclude 100% the elevated blood pressure is due to nephritic presentation or the kidney injury that is developed secondary to the severe nephrotic syndrome. So whatever the clinical presentation, it is a nephrotic or nephrotic. Now we have a case of collapsing focal segmental glomerular sclerosis. As most of you said, yes, it should be treated with immunosuppression. For primary FSGS, I will consider it primary. If you consider it primary and we try to search for all secondary causes and we didn't find a cause in this patient, so we'll consider it a primary FSGS. But we all know that collapsing focal segmental glomerular sclerosis is commonly to be found secondary to HIV, secondary to some drugs as pamidronate, and we will differentiate between primary and secondary FSGS by electron microscopy, as Dr. Ghada mentioned, according to the degree of food processes effacement. And I discussed this in details in the case that I was mentioned before 2 months ago, secondary to low birth weight. So in the presence of nephrotic range proteinuria, yes, we have to start immunosuppression. In case 5, an 18-year-old man was referred to nephrology after being found to have proteinuria by urine dipstick during routine evaluation. He reported a significant family history of kidney disease. No data were available regarding family members' kidney biopsies. He was born at full term with normal birth weight, and his hearing and vision tests for school were normal. On examination, his blood pressure is good. His examination was unremarkable, and he didn't exhibit any dysmorphic features or edema. His serum creatinine was good. Serum electrolyte levels, serum albumin, and the complete blood count were all normal. The urine analysis 2 plus protein is 2 plus albumin, negative for glucose, negative for red or white blood cells. Urine protein to creatinine ratio 1325 milligram per gram. Albumin to creatinine ratio 835 milligram per gram. Right kidney is 10.5 centimeter, left kidney 11 centimeter with increased echogenicity, but no hydronephrosis, stones, cysts, or masses. He underwent kidney biopsy because the patient has proteinuria, but again, is a protein creatinine ratio of 1 gram and 300 milligram is an indication of kidney biopsy. This is debatable. And again, this is what I discussed in detail in the case I presented 2 months earlier of a patient, young female patient with non-nephrotic range proteinuria. And at the last, we diagnosed her as FSGS secondary to low birth weight. So to do a kidney biopsy in this range or not, as I mentioned, it is debatable. Most of the experts will not do biopsy. They will follow the patient, and they will do biopsy only if there is progression of albuminuria or increased in serum creatinine. But this patient underwent a kidney biopsy. Light microscopy showed 42 glomeruli, which 10 had global and 3 had segmental glomerulosclerosis. The remaining glomeruli were normal. So this is a case of focal segmental glomerulosclerosis. There was no interstitial fibrosis, tubular atrophy, arteriosclerosis, or arteriosclerosis, immunofluorescence, no stain at all, electron microscopy, diffuse food process effacement, no electron deposits. So the case is focal segmental glomerulosclerosis. The question now, what is your next step for diagnosis? And would you do genetic testing for the patient or not? The next step for diagnosis is to differentiate. Is it a case of primary or secondary focal segmental glomerulosclerosis? How would we differentiate, as Dr. Ghada mentioned before, according to the degree of food processes effacement in electron microscopy? And I will show you the approach now. But I want to ask you, would you do a genetic testing in this patient? There is an opinion with subnephrotic range is going with secondary. Not always. Yes, subnephrotic range proteinuria. Always, not always, almost always suggest secondary, but it may be genetic. So let's go through the approach. Focal segmental glomerulosclerosis lesion on kidney biopsy. If there is a clinical presence of nephrotic syndrome, you have to diagnose according to the degree of food process effacement. If there is diffuse food process effacement 80% or more, so it is likely primary focal segmental glomerulosclerosis and treat of immunosuppression. And if no response for immunosuppression, consider genetic testing. Okay, if there is segmental food process effacement, whatever the presentation was nephrotic syndrome or nephrotic range proteinuria without hypoalbuminemia, or subnephrotic range proteinuria, if this segmental food process effacement, so it is probably a secondary focal segmental glomerulosclerosis. If the cause is clear, so treat the cause and don't start immunosuppression. If the cause is not clear, you have to consider genetic testing. And don't start immunosuppression. Start general supportive treatment. If there is no genetic abnormality on genetic testing and no identifiable secondary cause in this patient, this case is diagnosed as focal segmental glomerulosclerosis of undetermined cause. You have to monitor proteinuria and serum albumin without starting immunosuppression. And if there is worsening of proteinuria and serum albumin, which means that nephrotic syndrome developed, you can try immunosuppression. If there is nephrotic range proteinuria without hypoalbuminemia or subnephrotic range proteinuria and there is diffuse food process effacement, this is probably genetic and you have to consider genetic testing. But some cases may be primary FSGS with nephrotic range proteinuria but without hypoalbuminemia, not full-blown nephrotic syndrome or even subnephrotic range proteinuria. These primary focal segmental glomerulosclerosis cases may be presented late after some sclerosis, after the sclerosis has been advanced, which causes lower grade of proteinuria due to the sclerosis of glomeruli. I mean that it is a neglected primary focal segmental glomerulosclerotic case, which progressed to chronic kidney disease with fibrosis and sclerosis, and this may be the cause of this presentation. But most probably, primary FSGS presents with nephrotic syndrome, full-blown nephrotic syndrome. Okay, but as I mentioned, in this situation, primary FSGS may be of late presentation with advanced sclerosis and fibrosis, which causes little protein excretion. So in this case, we will do genetic testing or not, according to the degree of food process effacement. And case 6, 25-year-old woman, presents with edema and foamy urine, 3 weeks of evolution. She doesn't report a pathological personal history. In system review, there are no other alterations. On physical examination, only edema, no hypertension, no skin or mucosal changes. Hemoglobin 13, hematocrit 40%, CBC is normal, serum albumin is low, proteinuria 9.7 gram per day, urine sediment, there is a few RBCs in urine, about 8 to 10, erythrocytes per high power field, no leukocytes, no casts, ANA is 1 to 160, it is positive, anti-double strand is positive, C3 is consumed, C4 is consumed, tests for viruses are negative. So it seems that we are facing lupus nephritis, as Dr. Ghada mentioned. A biopsy was done. Which class of lupus nephritis is this? What do you think? What is the pathology? We have different options in the chat between class 3, class 5, and mixed class 3 or 4 with 5, class 3, class 5. Yes, actually it is a membranous nephropathy. You can see here a thickened glomerular basement membrane. This is very clear. This is very thick, right? Look, this is a very thick glomerular basement membrane. There is no proliferation actually. The capillary lumen is clear. The capillary lumen is totally clear. So there is no proliferation, right? So this is a membranous nephropathy. And this is approved by the deposition of IgG and C3 in a granular pattern. Can you see the granular pattern in the wall? And you can see that the granular pattern or deposits are facing the outside part. That means that these deposits are subepithelial. Subepithelial deposits of IgG and C3 with membrane thickening is diagnosing membranous nephropathy. Case 7. This is a 43-year-old man, presents with edema lasting 4 months and is found to have nephrotic syndrome, proteinuria 40 gram per day, low serum albumin, serum creatinine 1.1. His anti-PLAR antibody is positive by ELISA. His autoimmune workup, viral markers, and malignancy screening are negative. So we are facing a membranous, a highly suggested, or there is a high suggestion of membranous nephropathy because of the positive anti-PLAR. And as you said, it will be usually primary because the anti-PLAR is positive with negativity of the workup of the secondary causes of membranous nephropathy. So the question now, we are facing a case of primary membranous nephropathy with these criteria. What is the most appropriate next step? This patient should be started on ramipril, empagliflozin, a diuretic, with a wait time for 6 months before deciding on whether or not to begin immunosuppressive therapy. Initiating immunosuppressive therapy with cyclical cyclophosphamide, corticosteroid, or rituximab may be considered for the patient. The patient may be started on tacrolimus only therapy. He should undergo a kidney biopsy to confirm the diagnosis of membranous nephropathy. I can see in the answers B, A, B, A, A. So the answers in the chat box between B and A. I want to ask you a question. What is the risk stratification of this patient according to risk stratification of membranous nephropathy? Is it low risk, moderate risk, high risk, or very high risk? What do you think? Let's see. GFR is normal or not? Away from GFR, we have proteinuria 14 gram per day. We have proteinuria 14 gram per day. Okay. So in 14 gram per day, I think, and also we have a very high antibody positivity. You can see here, if anti-BLAR more than 50, with proteinuria more than 8, okay, or more than 3.5, it is considered as a high risk. Some may consider it as a very high risk because they can say that proteinuria 14 gram per day may make the patient at life-threatening problem as, for example, thrombosis, acute kidney injury. So in both conditions, whatever you classified the patient as high risk or very high risk, for sure you have to start immunosuppressive therapy. And if I will start immunosuppressive therapy, for sure I will start cyclophosphamide or rituximab for this patient. So the most correct or suitable answer in this case is B. Case 8, we are approaching the end. This is the last case. A 47-year-old man with a history of primary focal segmental glomerulosclerosis presented with nephrotic syndrome. 9 months previously, he had been treated with prednisolone, and his 24-hour urinary protein had fallen from 8 to 0.3 gram over 3 months. His current medication, ramipril and simvastatin. So this is a primary focal segmental glomerulosclerosis that responded well to prednisolone. On examination, pulse is good, blood pressure is good, and there was edema to the level of both knees. Urine analysis 2+ blood and 4+ protein. Creatinine is high, serum albumin is low, urine protein creatinine ratio is also high, and serum cholesterol is high. So what is your diagnosis in this patient? I will say the diagnosis is a relapse. This is a relapse. Right, as you mentioned, because in the duration after complete of partial remission, this patient had remission, whatever it is partial complete. The proteinuria increased after reaching the remission, so this is the relapse. The question now, what is the most appropriate additional treatment at this stage? Candesartan, prednisolone and cyclosporin, prednisolone and MMF, or rituximab? What do you think the appropriate additional treatment in a relapsing focal segmental glomerulosclerosis that responded well to corticosteroid before? Dr. Noor Sadiq answered prednisolone. Any other option? Any other opinions? Yes, I will go for corticosteroids also. If there is a relapse, if the patient had a previous steroid-sensitive primary FSGS, you can repeat the steroids. If there is no contraindication, or if there is no intolerance to steroids, I will go for for the use of steroids. That was our last case. I want to thank you for your interaction and the presence today. I will upload the lecture on YouTube, and also I will put under the video on YouTube, in the description of the video on the YouTube, a link to download the PDF of this lecture. Thank you for your presence, and see you next month, inshallah.